It's a pleasure to be with you. The title of this session is Community Health Workers and Integration. There are no disclosures for this presentation. Objectives include review the attributes of community health workers, discuss the activities of community health workers, review common outcomes and impacts of community health worker activities, discuss basic public health concepts of changing risky behaviors, integration, class and status, roles, horizontal and vertical communications, and levels of message identification as it relates to community health workers, and discuss the current status of community health worker certification in the United States. Let's begin this discussion by considering a few key attributes of community health workers. Community health workers are members of and chosen by the community they serve, and as such, they are accepted by the community and have natural cultural awareness since they have been enculturated from childhood in their community's culture. Community health workers have established relationships with community members. These attributes of community acceptance, cultural awareness, and established relationships are crucial since many community members may be disengaged from and even skeptical of health systems and professional healthcare workers. In sub-Saharan Africa, 53% of the poorest households do not seek care outside the home, often due to clinic and hospital fees, other access issues, personal beliefs, and occasionally the misperception of the skills, attitudes, politics, and agendas of professional healthcare personnel. Providing home visits is a key part of most community health worker programs worldwide. Due to their being part of the community health workers are almost always welcomed to provide home visits. Community health workers tend to stay in their communities versus other health professionals who, even if coming from a rural community, often move to urban areas or emigrate to other countries that offer more opportunities for advancement with higher financial benefits. These attributes of being part of the community result in community health workers having strong community ties and retention at the community level. In the United States, community health workers help meet national healthy people goals by conducting community level activities and interventions that promote health and prevent diseases and disability. The value of community health workers not only applies to the United States, but can and does improve health and prevent disease and disability worldwide. Community health workers serve as a bridge or liaison between their community members and professionals in the field of public health, healthcare, and human services, helping provide essential health and public health services by establishing and improving relationships between these professionals and members of the community. To community engagement specialists, these trusted and respected community members are often recognized as informal community leaders and are known by many other titles, including horizontal communicators, opinion leaders, influential individuals in class, champions, community health representatives in Native American communities, community health advisors, lay health advocates, promotores in Latino communities, outreach educators, peer health promoters, and peer health educators. As community health educators or horizontal communicators, community health workers become role models, promoting, encouraging, and supporting positive, healthful self-management behaviors among their peers. As community advocates, community health workers help people get the services and the follow-up they need. Community health workers serve as patient coaches for disease management and as patient navigators, helping guide patients through healthcare systems. They also strengthen their community's understanding and acceptance of medical care, and as previously mentioned, help develop trust and better relationships between their community and other healthcare, and public health professionals. The recognition of their successes has led to recommendations that community health workers be included as members of healthcare teams to help eliminate racial, ethnic, and geographic disparities in healthcare. Getting community health worker activities and services reimbursed by health and healthcare funders has been a challenge. As previously mentioned, community health workers are lay members and informal leaders of the community who work either for pay or as volunteers in association with the local public health and or healthcare systems in both urban and rural environments. Community health workers are generally part of the community they serve and therefore share ethnicity, culture, language, socioeconomic status, and life experiences with those community members. Since community health workers typically reside in the community they serve, they have the unique ability to bring information where it is needed most. They can reach community residents where they live, eat, play, work, and worship. Community health workers are frontline agents of change, helping to reduce health disparities in underserved communities. This table reviews Health Resources and Services Administration, HRSA, Community Health Workforce Study findings, defining specific activities of community health workers in the United States. 82% of community health workers in the United States provided culturally appropriate health promotion and health education activities. 84% assistance in accessing medical services and programs. 72% assistance in accessing non-medical services and programs. 46% social support. 36% translation services, 36% transportation, 34% interpreting, 31% counseling, and 21% mentoring. Other employers reported duties for community health workers that include case management, 45%, risk identification, 41%, patient navigation, 18%, and direct service provision, 37%. Let's spend a few minutes reviewing a few basic public health concepts of changing risky behaviors, integration, class status, roles, horizontal and vertical communications, and levels of message identification as it relates to community health workers. This slide lists the major tools available to change risky behaviors. First, there is policy, developed by governments, local, state, and national, businesses, schools, and other organizations, implemented by statute and rule. Policy can be either good or bad. Good policy sets an environment encouraging healthy choices. Policies that support community health worker activities, certification, third-party reimbursement are necessary for effective community health worker programs. Another set of tools is the clinical setting with clinicians, providing one-on-one counseling with individuals and families, a powerful tool. The third set of tools are population-based interventions, the domain of public health. Population-based interventions can be subdivided into two subsets of tools, social marketing and community engagement. Community engagement is a common term used in our society, yet true community engagement is a relatively new concept in public health. Community health worker activities fall into the area of community engagement. All of these tools, policy, clinical, and public health, social marketing, and community engagement, are needed to change risky behaviors. The integration of these tools, breaking down silos, will be a key to effectively impacting risky behaviors. An Institute of Medicine report in 2012 focused on the need for increased true integration of public health and primary care to adequately address the goals of decreasing risky behaviors in the population. Even though this report focused on the integration of public health and primary care, the concept of increasing integration across other silos applies to the management function of organizing in general. In our current public health environment, appropriate integration, both internally and externally, is often necessary to meet an organization's goals and objectives. One of the most used diagrams from that 2012 IOM report is adapted on this slide. There is a continuum of integration from isolation to merger. In between those poles rest awareness, coordination, collaboration, and partnerships. Isolation means that groups have no idea what others are doing. Awareness means that groups are cognizant of others, working in common areas of interest, but have no engagement between groups. Coordination, collaboration, and partnerships are defined as increasing levels of working together. Also, as one moves from the left pole of isolation to merger, there is increasing dependence or interdependence of groups on each other. Merger is the state of total immersion and fusion. Isolation and merger are relatively uncommon. Most experts feel that much of what is done currently in integration falls into awareness and coordination, with too little true collaborations and partnerships. The Institute of Medicine recommended that increased collaborations and partnerships are needed to meet true health and wellness goals in the future. Collaborations and partnerships are established through effective team building and boundary spanning work. Boundary spanning skills and competencies help public health effectively integrate across silos. Boundary spanning leadership skills are discussed in other sessions of the North Dakota Public Health Training Network. Community health workers, as respected individuals from a community, can provide an essential bridge to integrate communities with the services provided by governments, businesses, other organizations, clinicians, and public health to change risky behaviors through enhancing collaborations and partnerships as recommended by the Institute of Medicine. All societies have elements of class and status. Class is defined as a continuum between open and closed. Open societies allow relative ease of communicating and moving between classes versus closed societies. The United States and England would be considered open societies, where India and Spain are more closed. Generally, there are three social classes in each community: upper, middle, and lower. Class is associated with certain behavioral expectations and is fairly well defined. For example, a person living in a certain part of town may be associated with a certain social class. Certain jobs may be associated with class. For example, a physician or lawyer may be considered upper class in some communities where other jobs may be associated with the middle or lower social classes. Superimposed on the class system is a status system and roles. Status is the social position assigned or achieved by an individual. Role is the acting out of one's status. Every member of a society or community has his or her statuses and roles. A man may have the status of son to his mother, physician to his patients, and elder in the church. In each of these statuses, a person is expected to fulfill certain roles or behaviors. Generally, people want to interact with people of equal or higher status and seek to move up in status with every opportunity. With that last statement in mind, a person can generally only significantly impact those of equal or lower status. Influential individuals are located at the upper end of each class in a community. These individuals are those informal leaders, the horizontal communicators, peer communicators, opinion leaders, influential individuals, and class champions. These individuals have exceptional ability to change the beliefs, values, and resultant behaviors of those in their class but equal to or below them in status. These last few slides point out a complexity of community engagement, appropriately engaging not only appropriate horizontal communicators in each class, but also those who are identified as community opinion leaders in specific areas like politics, health issues, spiritual matters, etc., that we previously discussed. Failure to appropriately engage the right messengers may result in program failure. The most effective community health workers would be those influential individuals at the upper end of each social class in a community. This is an important slide demonstrating horizontal and vertical communication between classes. Both horizontal and vertical communication is important for successful community engagement in changing risky behaviors. Communication from a higher class to lower class, vertical communication, generally results in high respect or prestige, medium message volume or capacity, and low to medium persuasion potential. This would be like utilizing a movie or music celebrity or professional athlete as a messenger. Public information officers often seek out these types of individuals since they have broad name recognition. Yet realize that these celebrities will only have marginal persuasion potential. They often suffer from silver spoon syndrome. Comments often heard include, "They don't understand the reality of life in my situation. It's nice that they care and I respect them for that, but they don't totally identify with my needs." Low to higher class communication we'll call reverse vertical communication is generally poor, associated with low prestige, message, volume, and persuasion. Horizontal communication is generally associated with moderate respect or prestige, but high message volume and persuasion. The utilization of horizontal communicators, which include community health workers, is a major tenet of true community engagement. Finding well-respected individuals of high status within their class who can effectively communicate horizontally within their class. Horizontal communicators are often informal, not formal leaders, and therefore often not effectively engaged and used in community engagement programs. These horizontal communicators have incredible potential to influence community and individual behaviors, and if not appropriately engaged, can undermine community engagement in a target area. Having said that, prestige support, formal leadership support, higher class to lower class communication, vertical communication, is important for successful engagement. An essential first step in community engagement is to obtain formal leadership support for the program or message. Their support will lend authority, respect, and prestige, though that support may not have great impact on message volume and dissemination or persuasion to lower classes in the community. Their non-support could be devastating, as you might imagine. A main point is that horizontal communicator messages, including those from community health workers within each class of a target community, is generally the most effective communication method to impact health and wellness behaviors. It's not only important to identify and engage horizontal communicators like community health workers, those of high status in each class of a target community who are recognized as leaders in specific areas, but those horizontal communicators must also identify with the message to be effective. NIDA identified 4 levels of identification with the message, including, first, no interest in a personal change of behavior or becoming a messenger to others. Second, interest in a temporary personal change of behavior, but no interest in becoming a messenger to others. Third, interest in a permanent change of personal behavior, but no interest in becoming a messenger to others. Fourth, interest in a permanent change of personal behavior and interest in becoming a messenger to others. Many public health professionals feel that current public health programs generally engage people in communities at levels 1 and 2 and rarely at levels 3 and 4. Horizontal communicators, including community health workers, must identify with a message at the 4th level or nothing will happen. They won't be messengers in their community. Some of the known outcomes of community health worker services include improved access to healthcare services, increases in community member health and screening, better understanding between community members and the healthcare, public health, and social service systems, enhanced communication between community members and health providers, increased use of healthcare services, improved adherence to health recommendations, and reduced need for emergency and specialty services. So community health workers can have a significant impact on community health and wellness, not only in the United States, but worldwide, and should be recruited, trained, and reimbursed adequately for their important work. Cost and access to medical care remain problems of worldwide scope, but are particularly severe in developing countries. It is estimated that 1 million more healthcare workers are needed in Africa alone to meet the health-related needs. Doctors are commonly concentrated in cities worldwide. In the United States, 84.4% of nurse practitioners and physicians' assistants and 89% of physicians were concentrated in urban areas where 80% of the US population reside. In Uganda, 70% of medical doctors and 40% of nurses and midwives are based in urban areas, serving only 12% of their population. Community health workers can enhance cost-effective health care and access in developed and developing countries, particularly in rural areas. Medical training for doctors and nurses is expensive, particularly in resource-challenged areas of the world. It is estimated that to meet the doctor and nurse workforce shortage in Africa, that world region would need to build 300 medical schools with a total training cost of over $33 billion and would take over 20 years to achieve. The training of community health workers is less expensive. Immigration of trained doctors and nurses to countries with higher salaries is common. In Zambia, of the 600 doctors trained since independence, it is estimated that only 50 practice in their home country. Community health workers may help resolve this shortage and distribution of doctors and nurses and are less likely to emigrate to other countries. They can be trained for specialized tasks such as providing sexually transmitted disease counseling, directly observed therapy for tuberculosis control, birth attendant services, limited medical and primary care evaluations and treatments. It has been estimated that 6 million children's lives a year could be saved if 23 community interventions were provided in countries with higher child mortality rates. Over 50% of these community-based interventions could be provided by community health workers. The World Health Assembly in 2006 called for a health workforce which is matched in number, knowledge, and skill sets to the needs of the population and which contributes to the achievement of health outcomes by utilizing a range of innovative methods. Community health worker training and assignment as part of the healthcare workforce is an innovative method to match skill sets to the needs of people. With training, monitoring, supervision, and support, such workers have been shown to be able to achieve outcomes far better than baseline and, in some studies, better than physicians. Much remains to be learned about the recruitment, training, functions, incentives, retention, and professional development of community health workers. Having said that, lessons learned in one country or community may not be applicable to another country or community due to such things as cultural, healthcare, infrastructure, and environmental differences, etc. With that in mind, it seems that community health worker adaptability to local requirements and needs is key to improving local medical outcomes. Community health workers are increasingly recognized for their powerful potential role in improving today's healthcare system. As mentioned, recent studies have demonstrated that community health workers can help to reduce costs and improve care, key goals of most governmental healthcare priorities. For this reason, many states in the United States are currently working to promote and formalize community health workers' role within the state healthcare system through certification. There is great variability in states regarding approaches to a certification process for community health workers. As with other healthcare professionals, some sort of licensure and certification credential for community health workers will be necessary for them to bill for and receive payment for the services they provide. Some states have established a board or work group to make recommendations for community health worker certification and training. In several states, private nonprofit organizations that support the concept of community health workers provide community health worker certification training that typically includes classroom training on core competencies, a practicum or internship experience, and an evaluation of skills and/or knowledge. Development of national standards for community health workers' scope of practice, training, certification, licensure, reimbursement, and oversight is needed in the United States. An example of community health worker training would include the Community Health Worker Training Resource for Preventing Heart Disease and Stroke, developed and published by the Centers for Disease Control and Prevention in 2015 as an evidence-based, plain language training resource and reference for community health workers, as well as a curriculum that health educators, nurses, and other instructors can use to train community health workers. The updated resource has 15 chapters that show how community health workers can help individuals prevent or manage heart disease, stroke, high blood pressure and cholesterol, diabetes, depression and stress, and other lifestyle risk factors. This training material also includes sections on working with children and teens and helping individuals talk to their doctor and take medicines properly. In summary, community health workers conduct community-level activities and interventions that promote health and prevent diseases and disability. Community health workers serve as a bridge or liaison between community members and other health professionals. Community health workers can have significant impacts on community health and wellness. Development of national standards for community health workers' scope of practice, training, certification, licensure, reimbursement, and oversight is needed in the United States.